I've had many patients do amazing things that would not be possible without adequate treatments for their ITP.
And that's the beautiful part about the ITP community as well, is as a collective, we get to help and support them. And I know a number of kids with ITP that are happy and healthy and, doing their thing. Welcome to our special ITP in Kids series, part of the Beyond the Count podcast. This series is dedicated to children living with immune thrombocytopenia and the families who support them. We'll be exploring everything from diagnosis and treatment to school, sports and emotional wellbeing. We'll speak with leading ITP clinicians, hear from parents who've walked this path, and even chat with kids themselves, giving you a full 360-degree view of what life with ITP really looks like. Whether your child has just been diagnosed with ITP or you've been managing ITP for a while, this series is here to support you, inform you, and empower you every single step of the way. Today I'm joined by Dr Melanie Jackson, Paediatric Haematologist at the Queensland Children's Hospital and Medical Advisor to ITP ANZ. In this episode, we're speaking directly to parents who've just heard the words, "Your child has ITP." Melanie helps us unpack what that diagnosis means and how to talk to your child about what's happening in their body. If you're feeling overwhelmed, you're not alone. And this episode is here to guide you through those early days with some clarity, care, and support. Let's get started. Thank you so much, Mel, for joining us. I'm so excited to have you on the show.
You're very welcome. I'm glad to be here. I'm excited to talk about ITP.
Well, as you know, the topic of the podcast is we're talking about pediatrics and ITP, kids living with ITP, and specifically kids that have been newly diagnosed. So hello out there to any parents that are listening. I'm sure that there'll be quite a few over the next couple of weeks and months with this episode. So let's start, I suppose, with the basics. What is ITP? Why does it happen to kids? Do we even have an answer to that second question?
So lots of things to talk about here, Danielle. So ITP can be very overwhelming in the beginning when a patient is diagnosed with ITP. Initially, they've often come through various different avenues, emergency departments, doctors' rooms. They've had a lot of bleeding or bruising or nosebleeds. They've Googled those symptoms and all different diagnoses have possible. So everyone's pathway to getting their diagnosis can be very traumatic, and that is something I really do feel for patients. ITP is immune thrombocytopenia. So as you know, it's a low platelet count, and that is caused by the immune system. One simple way of looking at it, our blood is made up of red cells, which carry around all the oxygen and nutrients, our white cells, which keep our body healthy and fight infection, and there's a whole heap of different types of white cells. And then we've got the small clotty cells called the platelets. And all of these blood cells are made in what I call the bone marrow factory, the middle of our bones. And ITP is not actually a problem with the bone marrow. The bone marrow is making the platelets very well. But for whatever reason, the immune system has got confused. So often it will be an infection in the few weeks leading up to the virus, but it's usually in somebody that is prone to developing what we call an autoimmune condition. So the immune system has got a little bit confused, and instead of just fighting that infection or reacting to the immune insult, it has created what we call an antibody against the patient's own platelets. So consequently, the platelets are being produced very normally. In fact, in many cases, they're being produced much more than the next person. But the immune system is clearing them away, that those antibodies are attaching to the platelets and telling the body to clear them away too quickly, which means at any one time, the platelets are often very low. And because we don't have the same amount of clotting cells, that can make their bodies at risk of bleeding, of bruising, of getting nosebleeds, bleeding from the gums. Sometimes we see bleeding in vomit. Sometimes we see bleeding in the nappy or bleeding in the bowel motions. Occasionally, it can be bleeding in the urine. And for those teenage girls, they can certainly have very heavy periods, the symptoms we often see at presentation. Occasionally, we can see more serious bleeding when ITP first comes on, and that can be in the form of bleeding in the brain. But that's actually quite rare. Less than 1% of patients, well under 1% of patients, pediatric patients with ITP will present or ever have that complication. You asked, why does it happen to kids? That is a great question. And it does happen in kids not infrequently. As paediatric haematologists, we see this a fair bit, and as do the general pediatricians as well. One of the reasons I like to look at it is the immune system is still learning. Like the rest of the kid's body, it's still learning how to function. And a virus can sort of insult the whole immune system and make it get a little bit confused. And often in these cases, it just gets better quickly. But as you know, some people's ITP does last a little bit longer. And to be honest, we can't, unfortunately, and we find it very frustrating, just as I'm sure the families do. We can't answer why some people's ITP gets better very quickly and some lasts medium to even long term.
Yeah, and that must be really tricky for parents as well with kids with ITP, not being able to, have all those questions answered that you would literally have all answered for, other autoimmune diseases or other, things that kids pick up during, school and the general life of growing up as a kid, So, they all have bumps and bruises, but unfortunately with ITP, there is no definitive, answer as to how long someone's going to have ITP for. So,
yeah, exactly.
And over those, first few days, it can be really overwhelming for a lot of those parents, especially when they've got littler kids. But what would you say, what should a parent expect for the first couple of weeks, from diagnosis into that first 4-6 week period?
So with ITP, everybody's course is actually quite different. So the first few weeks can look quite different for different patients. So in those patients that have presented with what we sort of consider higher risk bleeding, so if they're having a protracted nosebleed that we can't stop, or if they're having a lot of bleeding in their mouth, bleeding around their gums, particularly those that are getting big blood blisters that are bleeding a lot, if they've had bleeding in their brain or their urine or their poops, those patients we usually straight away like to give some sort of immediate treatment to get the platelet count to come up. Now, I call these treatments temporizing treatments because they're not a cure for the ITP, but they're a short burst of something that acts in the immune system that temporarily hopefully allows the patient to have a better platelet count to protect them. So this is often in the form of a short course of steroids, so 4 days often of steroids, or admission to a hospital for an infusion called IVIG, of a donated blood product of other people's immune products. Sometimes people even need both of those things together, depending on the seriousness of their bleeding. Many patients will get these initially, depending on their doctor and the nature of their bleeding. But it's important to recognise that these treatments are aimed to temporarily bring the platelet count up. And another of the many frustrations of pediatric ITP, not everybody responds to these treatments. And if your child doesn't respond to these treatments, it doesn't necessarily mean that they're going to have ITP for longer or their ITP is more serious. It's just luck. And sometimes that means that we try the other types of temporizing treatments. We then monitor with blood tests sort of a week later, sometimes a little bit more frequently, depending on the nature of the bleeding. But we really are trying not to do excessive a number of blood tests on kids in the beginning, unless it's changing what we do. Some patients who don't have those serious bleeding at the beginning can expect to have no treatment, and we adopt what's called a wait and watch approach because many of these patients get better. And that can actually be really even more challenging than the treatment options for patients. And we appreciate that, how challenging that can be in terms of doing nothing. When you see a child covered in bruises and those little dots that we call petechiae, they've clearly got a bleeding problem, but your doctor is telling you that we're actually just going to observe them and continue to review them and do blood tests from time to time. Now, those decisions are always a joint decision between the family, the child if they're old enough, and the doctor as to what the most appropriate treatment is. Many will need those temporizing treatments, but also many, it is appropriate if they're not having what we call the mucosal bleeding from their mouth or their nose or their lower areas, then it can be quite appropriate to give the ITP some time to see if it will just go away. But in some cases, when the family don't want to follow that approach, or if they live a long way away from hospitals, then we can talk about giving those treatments even in the absence of the really serious bleeding. So everyone does follow a different course, but certainly in the beginning, what it will look like at the very least will be more frequent appointments with a doctor to talk about the treatment options. Some blood tests, but we do try and minimize them to only do the blood tests when we think it will change management. There are some doctors I've seen do weekly blood tests. We try not to adopt that if it's not going to change any treatment straight away. Though sometimes when we start a new treatment, of course, we will need to do more frequent blood tests as we're learning as that child responds to the treatment.
Now, you've been talking a lot about bleeding and not so much about the platelet count, which I think is really interesting. It's something that, obviously as a patient organisation, we advocate for with patients. It's not just about your platelet count. In the adult space, everything is so heavily wrapped around the platelet count and not as much around the bleeding risk. And I think it's really refreshing to hear that, from a paediatric perspective, the platelet count is the platelet count, but what are the actual risks, and is my child bleeding? Are they experiencing, nosebleeds consistently or ongoing? These are some of the times that we make sort of decisions on to change treatment or administer treatment, which I think is really refreshing.
Yeah, we certainly make our treatment decisions or recommendations with the family based on the clinical bleeding and the phenotype of the ITP as opposed to the number. It can be very challenging for a patient to see or their family to see a platelet count of 0. But the reality is, and just last week I had 2 patients who were very similar age who had been diagnosed with ITP at a very similar time, and both of them had a platelet count of 0 on this particular day. And that doesn't mean 0. It means less than 0 times 10 to the 9 per mil. So there are still some platelets, but it's rounded down to 0. 2 patients can present very differently to that. One patient can be having a lot of menstrual bleeding, mouth bleeding, nose bleeding. And the next patient who I saw with the exact same blood work had one tiny little dot in their mouth and really not even a bruise on their body. So it really is important to treat the scenario as opposed to the number, because we know that the risk, that's why we're always looking in the mouth, looking in the nose, asking you about the nappy, because we know those patients with those symptoms are more likely to run into problems than necessarily the number.
And yeah, it's very similar right across the board, both from a paediatric sort of teens, young adults, and even adults and seniors. If the patient has a platelet count of, say 30, and they're experiencing bleeding, yet roughly the same type of person has exactly the same platelet count but is not, you're very likely to treat the person that is actually actively bleeding as opposed to someone that's not.
Thanks to our sponsor Sobi for their ongoing support of ITP Australia and New Zealand and our podcast Beyond the Count.
So when you've got like say a 7-year-old, 8-year-old or older patient, someone that's newly diagnosed, where does mum and dad and where do you begin with trying to explain what is happening to the child and what they can do, what they can't do? Like, how do you start that conversation and how do you help, I suppose, mum and dad have those conversations too?
That's a really good question. And particularly with this sort of what I call sort of early adolescent sort of age group, because across the childhood age, we're dealing with sort of speaking with patients in all different age groups. Obviously, the babies, and this can come on in less than 12 months, so there's not really a lot of conversations to have there. But when in terms of talking to the patient themselves, but when you're dealing with a 7 and 8 year old, it's very important to be able to explain what is going on with their body in an age appropriate way, and also explain why we might need to change some of their activities. The goal of paediatric ITP is really to be able to enable patients to be able to have a normal quality of life and to be able to do the activities that they want to do. But the reality is particularly when they are having a lot of bleeding symptoms and their platelet count is not very high, we do need to talk to the patient about changing some of those activities. So I always start by I use my analogy that I was talking about earlier. I explain to the patient that their immune system is a little bit confused at the moment, and in all likelihood, their immune system will grow out of that. But it might not. And if it doesn't, we can certainly help them. That because the platelet count or the clotting cells are lower than the next person, then they might experience more bruising or more bleeding symptoms. And that in itself is not going to hurt them, but we want to change their activities a little bit to avoid them having a head injury to keep them safe. I always do there's always a lot of questions about sports and what sports they can and can't play. And I certainly, and if it was my child, I have sort of a list of sports that I consider safe, less safe. I mean, we all know that everything that we do, ITP or not, is taking a risk. So we can never remove all of the risks. But the reality is many sports are safe to play with ITP. But I always do, when I'm talking to the patient, the child themselves, I do say, I do include the parents in that discussion and ultimately say that it's a family-based decision what sports that sort of they will be playing. It's all well and good for me to say, yes, you can go play soccer. I'm comfortable with you playing soccer. But then if the mum and dad are biting their nails on the sidelines and it's affecting them, then maybe that's not the best decision for their family. So I sort of empower the parents to be able to make those decisions, but give them the information of what's more risk and what's less risk. But I make sure that I try and draw pictures of platelets for the kids, and I explain that these cells come together and they form a clot with all of those blood clotting factors, and just explain that it's just one part that's missing, and in all likelihood that would normalize again. But if it doesn't, we can help them. There's longer term medicines that we can help them to allow them to have fun like their friends and live a normal life.
Yeah, that's one of the big things too, is that obviously making those decisions and having those conversations with mum and dad. So it is, again, comes back to that shared decision making. It is a holistic conversation that incorporates, the risks, risk factors, safety, what's mum and dad comfortable with, what is the patient comfortable with as well, and making sure that it is a very fine balance. But, getting a balance, it does take a little bit of time, but having those conversations and those honest conversations, I think, are extremely important as well from a parent's perspective, but also from a patient's perspective as well.
So yeah, and it's also important to decide what's important for that patient. What is their quality of life? What are the activities that they like to do? Because that certainly changes some of our shared decision making with the family. One patient, we might be comfortable running a lower platelet count if they're not playing high-level sport. But the next patient, it might be in the exactly same scenario but wants to play. And I've had many patients play professional baseball, professional soccer, professional sports. And in those patients, we might suggest an introduction of a medicine earlier to allow them to do those activities. So it's important that we know our patient and we know what's important to them, as opposed to treating everyone the same.
So, and we get a lot of parents reaching out to us. Kids are newly diagnosed, and as you said, a lot of those children do self-resolve. But a lot of those questions from mum and dad are, did I do something wrong? What did I do? Where do you get that? I suppose from a hematologist perspective, a specialist.
We get it a little bit, particularly in the younger patients. The babies, we get it a lot. And of course, the answer is no. There is nothing you have done that brought on the ITP. It's nothing that you have eaten. It's nothing that you did in the pregnancy. None of those things. We certainly know that some families are more prone to autoimmune conditions. That's why we're always asking about the family history. However, in saying that, it often happens in families where there is no autoimmune history that we can elicit as well. Now, there has been a little bit of data to suggest that sometimes the immunizations or certain immunizations might trigger ITP, and people obviously have their own opinions about that, and fears of the immunizations later. But our feeling is if it wasn't the immunizations that triggered it, it most likely would have been the next virus that came on to sort of trigger the ITP. So, and again, from a hematologist point of view, we are all very supportive of giving those immunizations because we know that the risk, there's a current measles outbreak, and the risk of those infections can be much higher than the risk of the ITP. But people often do then debate their decision of the immunizations, and that's something that we can help support them through. And ultimately, again, it's their decision what they do moving forward. But certainly in terms of, some people feel poorly because they got flu or they didn't get flu vax that year and the ITP came on. We do feel that in the people that are prone to it, it's likely would have been any of those infections or the next infection that would have brought it on. But of course, there's a lot we don't know about ITP, and we'll never be able to prove that, or we might, but not yet be able to prove that. But certainly I'm very reassuring that there's nothing that has been demonstrated to bring on ITP, and you certainly didn't do anything wrong.
No, exactly. And that's the big thing about ITP too, right, is that there is no definitive test to say that it is definitely ITP or not, because it is a process of elimination. But especially in the children's space, the vast majority of patients do go into remission. So cross fingers and toes that we have you in the ITP community for a heartbeat, but hopefully you're on the other side of that fairly soon. But there are those patients, there are definitely those patients that do have their ITP prolong and continue, and there's so much support out there for those patients. There are so many options, like yourself, second opinion specialists, resources and assistance that we can obviously provide as well. So know that we've got you. You're not alone. You're not struggling on your own. We're definitely here to help you out.
100%. And we certainly in the last 5 to 10 years, we've seen so many new treatment options for these patients with ITP that does persist. Again, many of them will recover in the 3 to 6 months, and then a large proportion of the others will recover in 6 to 12 months. But we do know that a reasonable proportion, in the order of 20%, some people quote a little bit more than that, will go on to be 12 months. And some people have that real fear of the 12-month mark, meaning that it will never get better. And that's certainly not the case. Many of those patients, so half of the ones that make it to 12 months will actually get better in the next 12 months and many more in the next 2 to 3 years. But certainly if your child does go on to have chronic ITP, we have many good treatment options to be able to allow them to just live life normally and not think too much about their ITP, because that's what we want for them. We want them to be able to play whatever sports they want to do, to travel, to go on roller coasters, to do all the things and just feel safe.
Yeah, exactly. And I think that's the beautiful part about the ITP community as well, is that you've got amazing people like yourself treating these and working with these families and working with these particular patients, and we do the same as well. And then as a collective, we get to help and support them and help them navigate the 3 months, 6 months, 12 months, couple of years even. And I know a number of kids with ITP that are happy and healthy and, doing their thing. Happily doing their thing and pivoting and, talking, having chats with mum and dad to make sure that, that they're doing really well, but also having chats with some of the kids too, with permission from the parents to, see how they're doing and to see if there's anything else that we can be doing to help them along the way.
100%. Yes. I've had many patients do amazing things and amazing things that would not be possible without sort of adequate treatments for their ITP. So again, high-level baseball players, soccer players. So it's great to be able to see these kids thrive and do what they follow their dreams.
Yep, exactly. Well, thank you so much for joining us. It's been great having you on.
You're very welcome. It's been a pleasure to be here, and I look forward to talking with you more, Danielle.
Yes, we do have a series, a kids ITP series that we're currently recording, so you will definitely hear a lot more from Mel over the next coming months and even into the new year as well, so which will be very exciting. So thank you so much for joining us.
Amazing. Take care.
I hope you all got a lot out of today's episode. Before we wrap up, here are 4 encouraging takeaways from our conversation with Dr. Melanie Jackson. Number 1, ITP is not your fault. It's often triggered by a virus or immune response, and there's nothing that you could have done to prevent it. 2, many kids will recover from their ITP. Many children experience spontaneous remission, especially in the first few months. The immune system is still learning, and in most cases, it settles down on its own. Number 3, treatment isn't always needed right away. Doctors often use a wait and watch approach, unless there's any active bleeding happening. Decisions are based on symptoms and not just around the platelet count. Number 4, talk to your child in a simple, calm and reassuring way. Use age-appropriate language to explain what's happening to them and their body. Focus on safety, support, and helping them feel confident and not scared. A big thank you to Dr. Melanie Jackson for joining us today on Beyond the Count. We're so grateful for your time and for the care and support you provide our littlest community members and their families. If you're looking for support, connection or information, visit itpanz.org.au. You'll find The Count, our quarterly magazine, patient stories, treatment information sheets, clinical guidelines and a wide range of resources designed to help you and your family feel informed and supported. Most importantly, you'll know that you're not alone. There's a whole community here just waiting for you. If this episode was helpful, please share it with others in the ITP community and leave us a review on your podcast platform. It helps more people find Beyond the Count. We've got more expert conversations, patient stories and more coming soon. So hit the follow or subscribe button to stay updated. Thanks for listening as we go beyond the count together.